there's some interesting stuff. So we were just talking beforehand. When I started in the late 90s, it was IV O2 monitor. If I was so worried about their heart, I better put an IV in. And so we were putting IVs in everybody. Is that really what we want to do? So I take that fast forward to today. I have somebody that's relatively stable. They did have a little bit of chest pain, but I'm just, there's nothing else going on. Or they're feeling just off. And it's like, okay, but they're gonna have to draw labs when I get to the hospital. I'm not planning on giving any medicines. They're not gonna get any immediate medicines when we hit the hospital. Why don't I just wait, let them do the poke. They can draw the labs off the one poke, so I'm not multiple poking these guys. So it's just, it's a thought process that from where I started to where I'm at now. Not saying that that's what you need to do. You'll have your own guidelines on what you're expected to do, and you want to stay within those. But much like, so I'll take the other extreme of just because you can doesn't mean you should. There was a service in Western Wisconsin about 15 years ago now that got RSI. If you don't know what that is, but it's where we intentionally sedate and paralyze somebody, then intubate them. It's a very handy tool in really bad traumas or in certain medical conditions because, up to that point, they'd have to be unresponsive and not breathing, pretty much dead before we could intubate them. And we'd like to get control of their airway beforehand. This particular service had done 3 intubations the year before. The month they got RSI, they did 12 intubations. A very good example of we have something, we want to use it, and there was a big holy crap, what the heck, we didn't do that. So service that I did, so this was up at Lakes, we implemented it, we didn't do our first RSI for 3 months. So trying to have that focus on there. So tonight we're going to be talking about uninvasive procedure that does carry some risk, that just making sure it's clinically indicated and that we're ready to go. The other flip of that is a lot of services that are IV varianced are so low volume and their confidence level isn't there. We're wearing it as a badge of honor. I'm cool, I can do IVs. Yet we don't. So if you go back and look over the year, maybe had 10 patients that should have had it and nobody did it. I don't want you guys doing your first IV at 2 o'clock in the morning on the side of the road while you're waiting for the helicopter to land, because you know you're going to be RSI on this patient, and that's your first IV in 6 months. So finding those times when it's appropriate, be decisive and go ahead and execute on that. Close? Where are you going for? Okay. I'll mark that up here again later. So who can do IVs in your system? Have you given the guidelines out or talked about it at all yet? Okay. So just throwing it out to the group. EMTs. So yes, so EMTs actually can do the procedure. And I can forget 144E 101 subdivision 12, I think it is, that covers all that. Basically, the medical director has to say that you're allowed to do that. You have to have initial training, recurrent training, and have the sign off on all of that, which this will cover. And then I'm guessing you'll continue to do that periodically. So the EMTs are the only ones allowed, so EMT and above, so AEMT paramedic can do IVs here. EMRs are allowed to do all the rest of the support pieces to that. So we're going to cover how to spike a bag, what the different needles are, all the different components, because you're running 2-man crews generally?
We'd like to.
Okay. So sometimes 3, sometimes 2?
Well, we have to do 2.
Right, of course.
But
somebody's going to be busy.
yeah.
So generally, if you've got a sick patient, somebody's going to be doing, so it's a team sport, so then everybody's going to be doing all that. So some of your equipment here that you all going to get a chance to kind of poke the bag and just see what it all is. So who is going to be EMTs that have had the training, and we don't have a set number, the medical director, how many sticks you have to have before you can do it on a live person or anything like that.
He did
Yep.
not give us.
And I'm fine with that as well. My theory is we got the arms. He's willing to be poked, what do you say, 15? No more than 20 times? No. So, sorry. So, that's right. Speaking of Narcan, no. Oh, boom. So, if we're really desperate, I can be a pincushion, but I sometimes get the nice little. So, yeah. I was just telling these guys, I've jumped out of airplanes, been shot at, been in burning buildings, and I don't like needles. So I can poke anybody all day long, but I do. I finally.
Oh, nice.
So, stupid backstory, but yes. I didn't want to be that guy. I didn't want to be the guy that get out my certificate and suddenly, oh, if my mind could forget what my eyes can see with the EKG on, 3 clinicals in. And I've been doing this, almost 30 years, and my wife said, I think you're overthinking this, dear. So I finally went and got that about 6 months ago. So, yep, she said, you earned it. I went, all right, you missed. So she's got like 6, so. But I got bullied. So, in any case, so anyway, back to that. So, the EMTs can do it. EMRs can assist. The what we're going to cover in a little bit. The why. Why might we want to, or what would be the indications for establishing intravenous access? Sorry. Trauma patient. Okay. So if I roll my ankle playing basketball and my ankle's hurting. I don't know. Yeah. Okay. I might need.
Well, if they're dehydrated from being on basketball.
Could be. Or how about it's killing me and you're going to intercept and maybe Toradol or fentanyl or something might be appropriate. Or when I hit the ER, it might be nice to have that. Granted, EMTs, we can do good splinting and ice packs and all that other stuff. But yeah. So absolutely, there's nothing wrong with that. Major trauma, certainly could come into play there as well. What other types of things?
Cardiac. Dehydrated drunk people on.
So I heard cardiac.
Yeah, cardiac. Heat injury.
So cardiac, why is that important? Why would IV access for a cardiac patient be important? I'm sorry, I pace a lot. Just put it wide angle, we're good. And I talk too fast, so when you fill out your survey, just listen faster. Okay. So cardiac patients, why would that be why would intravenous access be important for a cardiac patient?
In case we got low blood pressures, we got to do bolus to bring the pressures up.
Certainly can be that. Yep, absolutely. Or again, let's say we're going to be hitting the ER and there might be an antiarrhythmic that needs to be placed, or we are anticipating an impending cardiac arrest and we need resuscitation drugs. Certainly, that could be there. Somebody else said dehydration. Yeah, probably a good idea. You don't get any dehydrated folks out here?
Oh, yeah, we do.
No?
Most alcohol induced.
This weekend.
Okay. What was there a festival, or is it just because you got the trail and it's such a recreational area?
It was a man. It was a man.
Just
Wanted Nate to have something to do.
just cause. Okay, that's fine. So yes, dehydration can be a good one. Many types of hypotension can benefit from fluid resuscitation to help fill up the tank. So there are other times where we don't want to do that, and we'll talk about that in rates and some of those fluid and types of fluid that we can use there. But so any number of those kinds of reasons. How about diabetic?
Absolutely.
So diabetic reaction, both hyper or hypo can sometimes benefit from IV access. And what are you guys using for your diabetic reaction, hypoglycemic patients? What are you using?
We have glucagon.
So glucagon and
Oral gel.
the oral gel. Is that what you're using currently? Are you going to keep your glucagon?
Yep.
Okay. And then you're going to add in D10. We're going to add that in now. Good. Just food for thought. We're looking at dodge of dropping our glucagon because it only works sometimes. Depends on your glycogen stores that are available to be released. And we have the D10 through IV access, so now we have that ability to get sugars. So one of those concerns had been, and I wouldn't change right now, but in the most dire of cases, we're a part-time ALS, we have 3 paramedics that float in and out, but with the D10 and IO, even the most critical of patients that if we can't get IV access, we could still do D10 through the IO in an extreme. You have to have a good conversation with your medical director about that. But there was a long-held belief in our guidelines that EMTs couldn't do IOs unless they had a GCS of 3. Well, turns out that was never in our guidelines. It was one of these things that had been handed down and handed down and handed down and handed down. And we looked at our guidelines and talked to our doc and he says, no, if they're semi-conscious, the lidocaine usually can kind of help with that IO piece, but there's no reason you can't. So if they're in extremis and you really need to do that, and if they're that gorked out anyway with a glucose of 21, they're not going to feel it anyway. So something to think about, because we outdate 90% of our glucagon, and it's expensive. Something to think about. Just add it to your list. I mean, a year down the road kind of thing, but add that to the, we're looking at just trying to every place we can cut a cost, but not minimize our clinical stuff. Okay, so diabetics is another one. How about strokes? Okay, why for strokes, just in general?
Well, you got for the, like, streptokinase and so the access, so.
That would-
faster or reverse.
There you go. So there's another opportunity there. Not to mention just even an 18 in the AC will help with if they have to do contrast or anything for the, any of those other reasons. So there are a number of patients that would benefit from that. So, so that would be some of the whens. So, and you'll have more specific, you're going to make sure they get their specific guidelines.
It's all
But
laid out in the new policy.
it's perfect. So you'll get those true ultra, those things. One caveat I'll throw in there. So we talk about trauma, major trauma, or we'll talk about dehydration or hypotension from whatever cause. A number of cases of, so we have trauma with a lot of blood loss. If we haven't controlled the bleeding, so let's say we now have an open container hypovolemic problem, that putting a lot of fluid in, so I'll go back to my days in the early, we would put 2 14s or 2 16s in the ACs and we'll be running fluid, and we're just, because we want to keep those pressures up. We'd put mask pants on, all sorts of stuff. Some of you guys might have seen that in the history books, but so we'd fill up all this stuff and we'd be 110/70, we got these great pressures. And as we're working this problem, then the patient's getting worse and worse and worse. And suddenly we got kind of this thin pink lemonade looking stuff pouring out of the holes because we've kept the pressures up. Don't let the clotting factors happen. So wherever the bleeding was happening isn't, because we got so much pressure. So there's something called permissive hypotension. So in some of those big cases, we can talk about that in rates in a minute, but so there are times in major trauma, yes, you want the access, but you don't necessarily want to pump a lot of fluid in. Because the solutions that we're going to be using, so we'll get into some more of the what, is, so you guys, most of you guys watched the video on the various types of solutions. So the one that's most commonly called, it's called normal saline or 0.9% sodium chloride injection, and we can list all the ingredients on here, but in essence, this is salt water. Is this particular solution, first of all, is it a crystalloid or a colloid? Anybody know? I don't remember if it was in the video, to be honest with you. Very good. So everything we're going to talk about tonight is a crystalloid. There are colloids, and those are large proteins that are in there. Pretty much anything you're ever going to have in your truck is going to be a crystalloid. So in this case, it's crystalloid, so it's basically salt water. Is it hyper, hypo, or isotonic?
That is hyper.
All wrong boldly.
Versus
0.9 is ISO. So that's why we use it, because it doesn't impact
that's right.
it doesn't impact cellular physiology. So it's about the same salinity as your blood.
As your body.
Right. So a 0.9% is what's called normal saline, because it's the normal, it's slightly acidic, if I remember. I don't remember that one. But it is, as far as the salt, at the cellular level, it's not going to shift into or pull out of, because water follows salt. And in this particular case, the cell and that are at the same salinity. So they're not going to shift across there. So we don't have any ability to hydrate the cells or dehydrate the cells. This is just simply volume. It increases volume in the tank. Okay, so even for the dehydrated patients, they're really not going to, at a cellular level, get much help from this. What it does do is adds volume back in. Because when they're dehydrated, the kidneys have pulled more out. If you really want to get down to there, so now the blood is thicker, and hematocrit gets worse. So it's a little bit thicker. The red blood cells and all the other crap are kind of sticky together a little bit more. This helps push that back out, and reestablish and thin that back out, but it gets your pressures back up. It gives it some volume because you've peed off a lot of the water. The body is now kind of, ooh, help. It's not going to rehydrate the cells, but it will rehydrate or top off the tank. So that will help with volume, but at a cellular level, we're not rehydrating the cells so much. But it lets the body do what it's supposed to do. It lets the kidneys be perfused better because now it's pushing stuff through. And so we still have plenty of red blood cells floating around out there. So this solution is isotonic, and this is what you're going to have in there. What if you were to get something that says 0.45 saline? That's hypotonic. So hypotonic, it's going to be less salt. If we wanted to really, if we were in a clinical setting in a hospital and we wanted to really rehydrate them all the way at the cells, let the cells really perk back up, we could give them a 0.45. But if someplace in your supply chain, something came through, it says 0.45, can you use that? Should we use that? What are the implications of that? You're going to end up, if they're already fluid overloaded and we were doing this for something else, we might make it worse because now it's going to go out into the tissues, out into the cells. It's not just going to stay in the circulation. We will fill that volume up, but it's going to leach on out into the cells, and we can actually, if you really overhydrate somebody, you can actually start doing cell damage and stuff. So, yeah, exactly. It's fluid shift. So, it needs to say 0.9. What if you had a 3.0%? That's hypertonic. So that's used rarely, but it can be used if you have like increased ICP and you're wanting to dehydrate or diurese essentially. So you put in a high concentration of saline. So you do a 3% saline solution and it will then take blood or fluid from the cells and back on out, and then the kidneys will pee it all off. So sometimes used for that. So just because it says sodium chloride, you have to look at the rest of the number. Okay? So that 0.9% is normal saline. Are you cleared for ringers or just saline?
He just said saline.
Saline's perfect. If for some reason lactated ringers were to get into your supply chain by accident and you get missed and you're going to do your checks and you go, whoa, that one is also isotonic. It does have a few other electrolytes and some other things in it, but it is essentially, so it's in the same class. And not telling you to go against your guidelines, but that one, if that's all you had and you absolutely needed it, would work as well. But there's a few drug interaction problems with it sometimes, and generally speaking, not a big deal, but should not happen. But I wanted to cover it a little bit because what's on this label is important. Okay. The other solution you're going to have in your truck, and are you planning on keeping this separate from the rest of your solution? So this would be more
in the IV grab bag, we just have the saline.
okay. Perfect.
This is just the D10 is just kept in the truck.
Okay. And that'll be near your rest of your diabetic testing, or just so that's clear. So your D10 is a totally different thing. While the way we're getting away with it in Minnesota by letting EMTs do an intravenous medication is it's at a point where the docs have all agreed, says it's still a solution. Usually D5 is about as far as that usually goes, but D10 we're allowed to do it. So this is as much sugar as anybody been around to seeing the medics or the hospital do the D50, that big old thing of, it's the same amount of the drug, it's just in a more diluted solution. Much safer. I'm trying to think. We pulled, when I was at Canon, we had already been to D10 and that was 5 years ago. So D50 has got a whole lot of issues with it. It's very corrosive. What's the right word I'm looking for? Yeah, it's very concentrated. And if we blow it and we're putting dextrose out into the tissue, it gets very necrotic and it can kill off tissues. It does a lot of damage. This can still do that, but we should be able to recognize it faster before there's any major damage. But anyway, we'll get to that in a minute. So we have an isotonic solution. 0.9 normal saline is our primary solution we're going to use. Lactated ringers is often also used as just a volume expander, but you guys are only going to be using this. The two are often seen as interchangeable. Okay, so that's the solution. Where else was I going with that? Who, what, when, where? Where are we going to do it? I'm going to get back to more of the what's in a little bit. Oh, that's fine too. Yes, so there's all sorts of places we're going to poke it. We're going to run it through an IV, but in what setting?
Depends depends on the situation.
There you go. So, where I'm going with that is, are you going to do it in the house? Are you going to do it on the side of the road? Are you going to do it in the back of your rig? Are you going to wait to get to the hospital and do it there? I mean, what are some of the considerations for that?
Back the rig is cleaner.
Sure, absolutely. Sure could be.
Brighter.
Yep, you have a lot more controlled environment. Absolutely. So,
Or you have a trapped patient in the car who's bleeding out.
Yeah.
right. So, it's going to depend on what it is. So, where I'm going with all of that is because of what we do in most circumstances, we don't want to delay our other treatments or transport to just get an IV, because most of what we're going to be doing is kind of anticipatory or prophylactic, being ready for something. Or we have a serious trauma patient, we don't want to sit and wait to do something that isn't going to be therapeutic for them now. So let's take that big multi-trauma, big patient, maybe bleeding. We have them out and accessible. Getting them in the back of our truck and getting going and doing it on the way is probably more beneficial, because if we're sitting around here trying to get an IV, we're focused on this neat little toy we have to play with, we're taking that time that they could be to have a definitive actual treatment at the trauma center. So not necessarily, we got to get this IV, because what we're doing for them in most cases, now we're going to talk about a couple of specific examples, but for the most part, this is an add-on so that they can get blood or whatever else they need when they get to the other end. So being able to get that done there, better. So go ahead.
Talked to a few ambulance groups around the county, and they say their protocol is if they can't get it in after 2 tries, they just go.
And I would argue, get it on the way. So if you've got it bad enough,
Yeah.
absolutely. But that same principle, so there's never an always and there's never a never. So just think about that. But is what you're doing going to make the difference right now? So think about that before. So we're sitting around and suddenly 20 minutes has gone by. We're well into our golden hour at that point, if that's kind of the time frame we're looking at. I would argue even on STEMIs, we have time is muscle. Is something we're going to do. Do we need fluid therapy for them to save them now, or can we get it on the way? So that idea, so even a STEMI, let's just take a STEMI that's got really crappy hypotension and we need to give them fluids. Sitting here right now may not be our best choice, because what they need is to get the cath lab. Let's get the IV going on the way so that we can add that fluid as we go. Certain heart patients you don't want to give a lot of fluid to in any case, so there's a whole other thing. We'll talk about that in administration. But there are other times where, yeah, that fluid could be a big difference in perking stuff up. So where I'm going with that is, so now on those really critical cases, oh my God, you want me to start an IV in a bouncing ambulance? Oh my God, what am I going to do? So now are the times where, yep, it's clinically indicated. Nope, we're not in a time critical situation. So why don't we get a few successful ones while we're sitting here in the back of our truck, ready to go in a nice controlled environment. Boom, got it. Hey, let's go. Now you have some successes, you've got a couple of streaks to go, you're feeling a lot better, so that when you are going down the road, or you go, we're all ready to do that, pull over for 1 second, drop your line, and then get going again. That kind of a thing. Doing it while you're moving is a challenge sometimes, so find out what you, yep, some of it's timing, so, and
Some of it's crazy driving.
well, that's a whole nother class we can talk about another day, okay?
That's true.
So,
I had a great one on Saturday. I don't know what.
were you driving? Oh, sucking up. I like it. Good. So, when it's clinically indicated, go ahead and get those done, because then you have, 80, 90% of our time, we do have the time. Take a few minutes. Just do it. Get it done right. Take all your time and prep it. She turned out all right. But, yeah, that car was wrecked. Well, you got me down on a whole other pathway there. Where was I going with that? So, want to be able to do that. Where am I when? I didn't have a pressure on. She was messed up. But I got a radial pulse and she's talking to me. It's good enough. So gave her the meds and it helped. But so, solutions. How many? You got cases of these, right? You got cases, good. So when we start, basically you want to make sure that you have the right solution. So we already talked about that, 0.9% sodium chloride. This outer wrapper is protected. It's just a protective thing to kind of help keep them from getting poked. It doesn't really, if for some reason it's not, it doesn't make the bag expired or not used unless you guys are internally going to do that. But, you know, we took it out thinking we were going to do it and we didn't. It can go right back in. If you do get warmers, just double check what.
There is talk about us doing warmers.
So they're expensive.
No, well, we have the blanket warmers in the truck. We want to store a couple days in there.
We could, but the problem is it shortens the shelf life of that.
Yeah, and I don't know what that is. I'd have to look. You have to look at the insert and check the manufacturers on how long they want. If it's under more than, what does it say, room? If it's greater than 77 degrees, till ready to use, avoid excessive heat. But I don't know what excessive heat is. The insert should have that. So that,
Blanket warmers, that would definitely work.
and
We haven't, but they're fairly under control is the issue with those.
so if you're interested, maybe do that, and you can put your
In the blanket warmer while you're, doing that.
People putting them up on the dash too.
that was my old school way. During the winter, we would do that sometimes, and it would keep it a little warmer, but that's not terribly reliable or be able to say we've had it at this controlled temperature for however long. But the blanket warmers has been what I've used historically, but usually with the blankets and then that, so it's not directly on it. So for me, so while we can go into a whole trauma triad of death and all the hypothermia and coagulation stuff, but room temperature, generally speaking, is okay. We're not dumping a whole crap ton where we're really going to screw them up. But in those deep winter months, probably, in my opinion, I'm not your medical director, but 1 or 2 is not a half bad idea. We have a long extrication, somebody out on a snowmobile trail that's been out, or an exposure kind of situation. Getting them 1 bag of relatively warm fluid wouldn't hurt at all and probably help some. So being able to do that, it does impact the shelf life. I can't come off the top of my head how long we can actually do that. But so outer package is just simply there as a protective mechanism during shipping and just storage and handling, but they're pre-scored so you can tear those all on open. I'm going to tear into this one as soon as we're going to talk about that. So also a nice improvised occlusive dressing if you need it. So you guys are using commercially produced one, the high fin or whatever. But yeah, so if you really do have a penetrating trauma, you can, this is really good heavy gauge and tape 3 sides, bottom, you know, you guys all know that. All right, so we'll start back up at the top. Big one here, expiration date. So this one's good through October of next year. You got some good fresh stuff, I like it. For whatever reason, saline was really hard to get for a while. 2014, and then during the pandemic, it was like, it would be available and then it was gone. It's salt water, what the hell? How hard is it to make? But it's still a medication theoretically. But making sure that. Now, if it does become in short supply, you can talk with your medical direction about, they can authorize up to X number of months after utilization if you run into that issue. There's a mechanism for expired drugs on how long after. Most pharmaceuticals are good for at least a year after, so that's when they start to really drop their efficacy. But in any case, so I'll just do another philosophical question. This is just a Johnism, but let's say we had one that expired in July of 23, and it's the only thing you've got. You got somebody with a crappy pressure looking like poo-poo.
You need port in a storm.
Okay, do that. Make sure you write up an incident report. Let the boss know and the doc know, and go. I'll get forgiveness versus permission. John only, but that same kind of idea that for whatever reason this is it. That's all you got. We actually do that up on our interview questions. You know, it's an expired EpiPen, but that's all right. More importantly, we're looking if they can make a decision. Right or wrong, the world is full of flat squirrels, so please just decide. One way or the other. It's okay. You wouldn't be wrong on the other side either. So, all right, so the other parts of this. This here is it's called a medication port. So you can add, you can't. One could add medication to this solution to create a drip of some sort. So we could add potassium, we could add epinephrine, we could add whatever we want. That's generally what this is used for. especially early on, especially if you're not terribly familiar with these, you're gonna try and puncture that one instead of this one, and you're gonna go, what the heck, this big thing isn't gonna fit into that thing, and suddenly water's flying everywhere, and you're going, what the hell? The blue is where you actually can put in your drip set, okay? So we'll pull that off in just a second. All right, I think that's all the major parts. Did I miss anything on the? You're supposed to be my back. So, all right, we're good. Yeah, whatever you said. Okay, so this is your drip set. Now the video did talk about drip sets, did we not? So, you already stole my thunder. So the number 10, is this a macro or a micro drip? It is a macro drip. So what does the 10 stand for? Somebody besides this group back here that knows everything. Anybody? What's the 10?
Someone told me I should have watched the videos.
10 drops per milliliter.
Boom! It's not necessarily it's the rate, but it's the volume that it takes to make 1 milliliter. So 10 drops equals 1 milliliter. Most of these drip sets come in, the most common are a 10 drop set and a 60 drop set. And the 60 drop set will have a little needle in it, and 60 drops equals 1 milliliter. It makes a lot of med math a lot easier because it's usually we're doing a medication over time. And so the 60 makes it a lot easier to do that if you're doing it. Now, granted, most of us aren't doing that. We're using pumps now, but it would give you that opportunity to do that, okay? So this is your drip set. This one is a macro. Some of them come in 15, kind of that in-between one. But most places I've seen 10, pretty universal across EMS as we do that. Where if you really want to start playing a little bit is adding an Iberitrol. So you actually have it's got about is it a 50 or 100 mil little chamber with another 60 set on the bottom for peds. So you don't fluid overload peds. So if you really want to start having some fun with that, you can add that in, which also gives you a 60 drop set, especially to go part-time ALS and you want to do an epi drip without a pump. Because, yeah, it's a lot of math, and I have to go get my calculator out when I do it. Anyway, so I'm going to tear into this. It's also got that. So at this point, we have still done, anybody not familiar with aseptic technique?
I think you should review it.
We'll review that. So the idea being things that are sterile should remain that. So I don't have my alcohol prep. Even to the point of doing things where, I've got my gloves on, but those are just clean, and maybe not even that. But when you hand over a bandage or you're handing over a swab, you can tear, I didn't tear that very well, but when you're handing your partner something, you're not touching it, you're limiting the amount of exposure to whoever might be contaminated. And then when we're doing this particular piece under the cap into here, we don't want to touch that. So once we take this cap off, knowing where that's at and being aware of going into and spiking your bag is not letting that touch anything else, because this is sterile under here and it's going into sterile here because we really want to minimize our chances for infection. So things like that, and when we start opening up catheters, how we're maneuvering them, when your placement, we're going to get into that, where sometimes we go over the thumb, you have to change your technique and where that's going. So we don't want to introduce any more icky, germy thingies on there. That's a really good technical term, right? Okay, so parts of the drip set. So this is called your drip chamber up at the top. Fluid builds into here, so you can see that it's flowing. We don't want it to completely fill up, and I'll show you a couple techniques on that. And then as we're flowing, you'll see a drip come out of here. And for 10 drips is 1 milliliter, so that's the volume. And so if we want to do rates, then we have to figure out how many drips per second to get whatever we want. So if we want to do 150 mils or whatever, we can do the math on that, and I'm not going to do it. Two different theories on this. So this is your roller clamp. So this helps you control your flow. So once your bag is hung up, this roller clamp, if you keep rolling it down, completely occludes it, you'd have no flowing coming through here, nothing going downstream, okay? So if you roll it up a little bit, and I'll show you again in a little while, but the more you bring it up, you get some couple of drips, but the location of this, so do you want it up by where the drip chamber is, or do you want it low down where the patient is? Totally preference. It's up to you how you want to do that. I generally put it up here, but doesn't matter. Okay. So my combat lifesaver class, they taught us to put it down here, because if I started it on you, my combat casualty, and I started that at about this, and I had to leave you, you could then control your own rate. So it was closer to the patient. That was why it was down there. But you may have a bag hanging up here, but you want to talk to your patient and see what's happening. You may want it down there. It's totally up to you, however you want to do it. Okay. I generally put it up here, but that's just me. All right. As we continue on down, these are some medication ports. Okay. This one is for if you have a needle or a blunt. I think you can do the needle-less, but the blunt through that one. And then this one's a lure lock. So you could hook up another IV line to it or another medication syringe. So if we already have this established and you intercept with me, for example, and I want to give them some morphine, I could hook into here, stop the flow upstream, give them the medicine, open it up, flush it on in, and do it all that way. And then down here at the very end, we have the lure lock. This is going to actually go into the IV hub, and that'll be our direct connection. So this has got a little twist. Same thing with this. We don't want to touch it. All right. And there we go. So that's all the stuff on the tubing. Trying to think of anything else I wanted to do with that. I think that's that. So let's spike the bag. Questions so far? You got any questions? Questions? Sorry. As adult learners, I'm supposed to ask questions and wait 10 seconds. Because the one to formulate the question, the other one to secretly go, don't ask a question, we're never getting out of here. Okay. All right. See, that was the DOT instructor course on it. So I pulled that off. I'm not touching in there. I get rid of that. So now this, and here's the trick. A friend learned this once. Make sure we're going straight in instead of sideways through. I have actually punctured my thumb with this before. So you take this nice blunt, whitey thing.
That is sharp.
Yeah. What's that going? Oh, son of a. Okay. So we go in here. There's a little membrane on the inside that we have to puncture through, but we want it upside down because gravity's working with us here. So we're going to go in, twist a couple times. I've already pre-clamped off my roller, right? Okay, so now we're spiked. Fill the drip chamber by squeezing it once or maybe twice, but that's about enough. Notice it's not flowing, all right, because my roller clamps all the way off. All right, well, what's in here right now? What's in the bulk of this air? So what if I hook this up and push all that air into them? Are we going to kill them? No. Probably not. We don't want to do it. Yeah, so unless they're in really, really, really bad shape, they'll be fine. Yes, there are things called air embolisms, but this is not enough to do that. So don't do it, but don't jump off a cliff if you do. It's not the end of the world. I don't want you panicking about it, but also make sure you flush the line. So, yeah, go right ahead.
So why you want your clothes off closer to the bottom so you don't have to worry about it?
Well, that would work too, wouldn't it? That'd work. So I like it up here, but no, that's not a bad idea. But, all right, so I'm flowing. And there's a few little bubbles, no big deal. Again, those few little bubbles are absolutely no big deal at all. So we got a couple little ones in here. Yeah, it's fine. It's no big deal. Okay, so there we go. We're in here. We've got line flushed pretty well down. Let me do it again. I'm probably covering up the microphone though. What? Can't hear me? Good, much better. All right, so now we're set and we're ready to go. This still is on, and so we're still protected there. Theoretically can do this. Ooh, look at that. We're kind of cool, right? So the higher up it goes, the little bit better pressures you can get, whatever. We can go into really crazy if you really want to put a lot of fluids in. There are pressure bags, or you can squeeze on it to if you really got to get somebody in there for giving adenosine or something like that, which you guys aren't going to be, so no big deal. So that's your setup. So for the EMRs and EMTs, this part is all well within both people's scope. And in fact, the EMRs helping the EMTs might be able to buy us a few extra minute or so while we're digging around looking on the arm, okay? There's your IV setup. Now, 250 bag, 500 bag, 1,000 bag. It's entirely possible that maybe liter bags aren't available, so you're going to get a 500 bag. Really doesn't matter. It's all the same stuff. It's just you'll use it or not. Okay. There's reasons for that sometimes too, of only 500 bags, so that you can only, if you were to unintentionally fluid overload somebody, you'd only give them so much. 1,000 still. Most healthy people can handle 1,000, can handle a liter of saline without even blinking. Most people run mildly dehydrated anyway. It really isn't there. There's a very few small subset that's going to be too much. So anyway, so there's that. And yeah, 5-second rule. Yeah, it works in food and IVs. It does. All right. So in here, your glorious leadership has obtained. Oh man, my knife is still in my. I had to go to court today for my kid, and my knife. I am so naked without my knife. Holy crap! Thank you. I'm just going to give that back to you like that. All right. Oh man, that's why everybody's staring at me. I don't have my knife on. So this is your your IV start set. So a couple of pieces that you're going to find in here that are pretty handy spandy. Oh, you guys are doing the iodine. I like that. Do you care, or do you have to, or
What?
you have iodine and alcohol?
I don't use the iodine.
Okay. And there are varying schools of thought on that, but basically we have stuff to do skin prep. What filter are you?
Media officer.
What filter are you using?
We just got that.
Hashtag Silver Fox Safety, please. That's my consulting company. So
Yeah, I like the name.
yeah, I don't know how I came up with it, but all right. So a couple pieces in here. This is your brand name Tegaderm, because you guys get nothing but the best. We use the Vanguard, and I like Tegaderm better. But so this is an occlusive dressing as well, but not meant for penetrating trauma. This is just basically covers up your IV site. This is a handy-dandy little thing which we're never going to use. It's who started it and when and whatever. So one of the things very early in my career, North was if they didn't use iodine for their IV starts, if EMS hadn't used iodine to do the start, they would change the IV out immediately. And then for the longest time, they would only leave an EMS placed IV for no more than 24 hours. Yeah, stupid. It was this whole, because early on we were still a little bit of, I don't know if we trust them kind of thing. So, but iodine and alcohol, in my experience, doesn't make a dang bit of difference. It cleans everything up that way. But you can do the iodine first and the alcohol after, and everybody's good, especially if they're really sweaty, dirty, whatever. Okay, and then a 2x2, which can be handy if you don't tamponade when we're starting it. You get a little bit of leakage, clean it up, or if we miss and we want to be able to put an easy bandage, so you've got a 2x2 ready to go. So before I get started, and then the tourniquet. And
Aren't the burritos that
well, these are a little, they're not so bad. They're a little smaller than what I'm used to. Where's my big IV arm? Where'd my big IV arm go? I lost it. Oh, it's right in front of my face. It looked like your arm for a second there. Yeah.
She's a bodybuilder.
I know. I was like, all right. So this was in the back seat of my car, and my wife pulled in the other night, and she thought, what the hell? Oh, you're doing a class. Okay. So this is kind of the one that usually comes with it. They're both fine. Either one will work. But so anyway, so there's your tourniquet. This is a venous tourniquet. This is not used to do arterial bleeds. So you guys using cat tourniquets probably. Most everybody is. So this is not going to work for major bleeding. This is a venous tourniquet, because what we want to be able to do is put it on tight enough to stop the blood flow from the veins going back to get things to, because everything's going back upstream. We're going to block that off, start to build up, and they should become a little bit distended. Helps us find where the veins are, be able to start our medication. If you're having a flow problem where you're not really getting a lot of drips, take a double check and make sure this has been removed. A friend has told me that on multiple occasions. So, yeah, I talked to, it happens. All right, so that's what's in your kit. So this, and then your tape. So this is going to cover up where the IV itself goes. This There's a couple of different styles to doing that, but you have just enough to get into trouble, but actually not too bad. So you'll tear this off, and in most of my experience anyway, I end up, they do not. And in a lot of cases, I actually do most of this before I get my gloves on, yep. So for me, I actually tear it again because I don't need all that much surface area, but I do need still some tape. So I'll usually tear 2 pieces up like this, but you guys can play with that as you will tonight as we start poking things. Okay, so there's my tape. You want all of this stuff prepped before we get to the next step of the actual needle. So this is out and ready to go, and even here, I tend to want to, for the very reason you're talking about, it's a lot easier to start grabbing edges when you have your gloves on. Or you, my partner, are going to be able to get some of that prepped.
EMR can be getting this part ready.
1,000,000%, absolutely. So even to the point of, it's depending on what you're thinking, you may not even want to open this up. But in any case, so those are the different pieces of that. Okay, moving on to the next piece. So you guys are just carrying the 18 and a 22? Okay, all right.
Three of each in each bag.
Okay. So this is your IV catheter setup. Okay, make sure I got those out there. Color coded, and I haven't seen any variations other than the gray, so orange, gray, green, pink, blue, yellow. Different manufacturers. At one point, again, 20 years ago, we got an odd brand in there, but they're going to be color coded, so they're pretty easy to do. But what does this number mean? So 18 gauge. Sorry, was that? Yeah. Yeah. So how big a hole it's going to make, but what is gauge? So is an 18 bigger than a 22 or smaller?
Bigger than a 22.
Okay. So they're reverse. So
Smaller the number, the bigger
the smaller the number, the bigger the hole. So
Same as a shotgun.
thank you. Good. Somebody else said it. So for me, I was like, oh, 12 gauge is bigger than a 20 gauge. Okay, I'm good. So, okay, that translated well to me too. And any electricians will tell you too. Wire goes in gauge as well. So in any case, because you're only going to have the 2, there's a couple of things, and I'm not going to dig terribly deep into it. For those of you that like to study and take notes, I'm not looking at anybody in particular. There are some implications for actual just pure raw size of how big of a vein can handle what size gauge of catheter. So if we end up putting an 18 in a teeny tiny hand here, even if we can get it in there, it's going to be blocking it off so much, there's nothing down from upstream that's going to be able to get past it, so it's really not going to do what we want it to do. So in EMS, generally 22 to 18 is kind of the range. So 18, 20, and 20, or 18, 20, and 22s are pretty common. 16s we do carry at Dodge, but we just don't use them. We don't need that much volume. An 18 gets plenty in there. So I have someplace in this PowerPoint that I started to do on how much you can actually get into a particular, how many liters per minute you can do. A 14 or a 16, you're getting like 200 milliliters a minute through those really big pipes. You don't want that much that fast usually. Now, if we're doing blood replacement, maybe we do, I don't know. But for what we're doing, an 18 is plenty of what we're at. So go ahead.
The difference between the two, like body type, age, like would you use one or the other for one or the other?
Yes and no. Mostly it's going to be, well, you used any port in a storm. Sometimes that comes into play. So maybe all you can get is a 22, but it's going to be in the AC, which is plenty that would be able to handle that. It's more just the size of the vein. Some of it has to do with how much volume you do want to be able to put in. Because if we have somebody that's very dehydrated and we really want to fluid resuscitate them or give them fluid, this 22 is going to take an awfully long time to get through there. So I'll even go back to the D50 when we would use that. That's like KO syrup. It would take me half an hour to push that thick fluid through this teeny tiny little thing. So my starting point routinely over the years has been 18, and I've switched that to 20s because for the most part, that's plenty. Again, more volume, that's what's going to drive what you want to do. So if you have a vein that can accommodate it and you are anticipating fluid replacement, you're going to lean towards your 18. If it's simply you're going to go, I want access in case we need to give some fluids, just maintenance fluids, or we're anticipating medication administration, the 22 is probably just fine.
Or the nursing home patient.
Or then we start to get into those fragile, little teeny tiny. And so that may be all you can get. And it may be even an AC, and they're just so fragile or you can't quite get where you need to, so then you're going to need that small catheter. So those are going to be your size challenges. The drawback when you get down into, starting even in this 22 range, is because it's so small, your flash, so when you poke through, you have to just give it a second or so. Sometimes it takes just a little bit for that flash to actually happen, where on an 18, poof, it pretty much goes right on in. But you go up to a 16 or a 14, and I'll show you, I'm going to turn one of these open. So one of the other problems though there is you get a 16 or an 18, the bevel sticks out so far beyond the catheter that you can be in the vein getting flash, but your catheter itself isn't in the vein. So you could, if you don't do the follow through, then you bounce the catheter up off the top and now you blew it. Okay, so here's your IV catheters, Gelco, whatever variation on the theme, but it's got a safety, it's got its own sharps kind of piece. It's not 100%, but it draws back into there. So I'm going to take this off. There's the rest of your stuff. And I have not played with the spring loaded, so this is going to be fun. I have. It's just been a while. Okay, so you've got a couple of different pieces of this. So you have your needle. There's a bevel on the needle because that's hollow. We're going to introduce that in. And then you have the catheter itself. There's a little plastic Teflon straw that comes off the top of that. This is one of the, I'm just going to cover it right now. There's one of the complications, it's called catheter shear. If you start to advance the catheter and you change your mind, don't pull back, you have to withdraw everything. Because the concern is if we try and pull it back, there's a small chance that that straw might bend just enough and get a small piece of the plastic. The bevel might cut that off, and now we have a piece of plastic floating around that could become an embolism. So it's what's called catheter shear. So if you start to advance, do not pull the catheter itself back. Once that started to advance, it has to stay there or continue to go, or you have to stop the whole thing, withdraw everything and start over. Because the risk of doing that, you can cut off a piece of plastic and stroke them out, or PE or whatever else. That's the concern. Doesn't happen very often, but it is a real risk. So those are one of the big risks. The other one, of course, is infection. That's one of the other big ones. Infiltration or that can become a problem too. All right, so you got your catheter. This one's green. There's your hub. When you pull it on out, I like to do this real quick. Make sure that I'm not pulling it off, but just enough to break it. Occasionally when they come out of their package, there's still just enough of a connection that, ooh, it doesn't want to go. So just enough to just twist it a little bit if there's any residual plastic to plastic kind of melted together, kind of stickiness is gone. And then I generally hold it like this and then use this, keeping some back pressure, and then we'll go in. I'll show you on the arm here in just a second. But in here is your flash chamber. If you kind of look in that middle piece, as the bevel goes into the vein, blood goes down the needle, fills up into the flash chamber, and you go, okay, I'm there, I see that. Then I know I'm in the vein, and then we just move that across. So here's my best way of doing this. So we'll skip the skin, but we go through the skin and poke into the vein. So about there, I'll get a flash. We should see blood filling up in there. Flatten out a little bit, go just a shade more, and then we advance and then I push down on the thingy, and it's gone. So, and now of course I can't take it back out and reuse it. But, okay.
I have cases of those too.
Yep, that's great. Because I forgot the other step. So we do that, but before we retract the needle completely, what we want to do is upstream, you tamponade, you squeeze down. So if we're doing, say, the AC, let me see where, so I'm going in, boom, I'm going to push here, retract my needle. Because I'm stopping the blood flow, I can, am I doing that wrong? Yeah.
No, you're right.
I'm right, yep. So I'm doing here, and then hook up my stuff, and then I can release it, and we can start flowing stuff.
Otherwise, you're pouring blood everywhere.
Yep, and sometimes it still happens. If you're really fancy, the via valve version of these actually has a valve built in that keeps that from happening. But it's kind of sweet. In any case, so that's what the needle looks like. Where did I do? Here's this. That's safely in there. This isn't going to teach you as much, but you want to see the straw? It's fine. Sorry. Okay.
Throwing things at me.
I am. All right. And this one you cannot do a blood sample off of for your glucometer. So,
If you,
Go
if
ahead.
you miss, you can keep the same needle and keep trying. Like
Nope.
You don't, you try it once.
Try, one
Nope.
hope, one try.
done. Because we've introduced some other stuff, we'll stop,
Redo.
re-clean, and then redo.
That's why there's three.
There's
needles
multiple attempts.
of
Absolutely.
Of each side. And then-
Okay.
Yep.
Okay. Don't do the first time.
Nope, just star all over.
Okay.
Okay? So, here's another one. You can tear it. There's a complete one. Tear it open and look at it.
Sharing.
We donate blood all the time. This is not,
Fine.
yeah. It's probably, is it silicone or is it plastic?
It's plastic or Teflon or someplace in that, but
It's not Teflon, it's the Teflon, yeah.
yeah,
Teflon squishes.
plastic. Plastic enough. But it's definitely not silicone because most things can't have silicone in them anymore. Or latex. Latex is what I'm worried about. You know, it's a plastic of some sort. I'm sure it's on their insert. It's not on the side of here, but all right. Henry Schein at least, right? Where'd you order them from?
Boundary.
Oh, wrong one. You a member of MAA yet? I can't remember if you are or not. Well, we have to fight about that later too. Okay. Where was I going with that? That's the gist of what we're going to talk about. So some of the risks. Catheter shear we talked about. Infection. So being able to do the skin prep, so I'll just use an example, is, so we're going to have to use the iodine. I'm not going to do that on my mannequin arm here, but so using this, wherever you need to get cleaned off that you're going to do your site. So we'll start off, I'm kind of doing this backwards, but I just wanted to cover. So start where you're thinking you're going to try, and then you start there and you slowly make circles on your way out. Apparently we've leaked a lot of blood out of there. In any case, that's kind of the idea. If you need to do it a second time or a third time, grab more. I'm guessing you got more preps floating around. You got a whole,
I have a whole stack
Yep, you
of
do.
extra preps
You did.
pocket in there.
Yep, so that's also going to be handy. So here's another one. Okay, so the idea being that one hasn't been sprung. Okay,
That's the one you let me open.
so what size is that
Sure, I
one?
can open it?
You can open the cath, take the cath off.
I would have frickin' stuck it in his arm too.
That's right. Take that off. Don't push the white button because that'll retract the needle.
Okay, I see the right button now.
Okay,
But now that's not, you broke the sterility of it.
Saying
Right.
I'll be names.
right. So we can't use it unless you're ready to go.
I'm not ready.
We're not going to do that. But this is just the practice one anyway. Okay. So
Not the time, sorry.
Yeah.
you are 1,000,000% right. Dark humor. I love it. Okay. So wherever you're going, some people you're going to need to do more. Some people are going to just one is plenty. So however you want to get it clean, get it clean. But once that's done, we don't want to touch that area anymore. So finding where you want to go is going to be the important part. Okay. So where we can go, there's a number of places on the arm because I think we're just about done talking about stuff. But infection. So that's the other one. Phlebitis could just be irritated. That can happen, but that's not something we have a lot of control over. And then infiltration. So if we were to go through, so either we bounce off or we go through into the other side, or in some cases, even though it's there, they have such fragile veins, it might leak out back around the catheter in certain cases. Or when we're putting enough pressure in there, they've got fragile veins and it pops the vein, it might start building up outside the vasculature. So now you're into the tissue outside. And so when you're flushing or when you're flowing it, if you start, so we put it in the hand and now we see a little bubble forming up above, we need to stop the IV, go ahead and pull it out, put direct pressure on it, and we want to catch that the sooner the better. On the back of a hand, it's usually easier to see if it's stuck up in here. But even up in here can you can still see it. So if you do blow it and you start to flush, or you have to check it periodically as we're going. So if we have an infiltration, saline itself, not that big a deal because the body will absorb it and it'll be fine. D10 can be a bigger deal because it's a little bit more caustic or whatever, can cause some necrosis. And like D50 is super hypertonic. It screws things up badly, but you're not giving that. So the sooner you catch that, the better. If you do have infiltration with D10, you want to make sure you note it and that the hospital's aware of it because they may need to do some other treatments on that. So, all right. Those are all the the risks. I think that was all the risks. Okay.
Joey, do we have a place where we have to do, like, do we have to do up here? Do we can we do it here?
Well, typically, you want to start low and work your way up.
Yep. And we're going to go over that, but keep going.
But again, though, if you need to get that IV in and you see a monster right here, you know you can pop it. I go for that. Like if you have a dehydrated patient, when you know that you're low, you're going to want to go to where you can see one because you're not going to get any on a dehydrated patient or a nursing home patient. I just put an IV in a nursing home patient just last week, and I just went right for this.
Yep. Some of that's going to be confidence level as you're getting started. That can play a factor. So if you've got a to start with, because it's going to help you get better at it.
And then you start going to church and you're walking down the aisle for communion or whatever, and you're looking at everybody's veins.
Because you're going to be doing that for the next 6 months.
I've already been
Get
there.
that veins on that one.
I still do it. So my now wife caught me feeling the vein across the top of her foot with my toe. As I was touching her, we were in bed, and I'm kind of going, ooh, that'd probably be, knock it off! Sorry, dear. She caught me. Sorry. Yeah, you're right. We're weird. Very weird. So, the other risk is fluid overload. So you do have some people that are very volume sensitive. So part of, once we start doing this, if we were to dump a lot of fluid in, one of the follow-up reassessments is adding in lung sounds. That's going to be one of your key indicators. So somebody with really profound heart failure that is already fluid overloaded, so they've got a lot of fluid, they're on diuretics, they're kidney failure, their kidneys aren't working so well, and for whatever reason, if they're having horrible left-sided heart failure and way overloaded on fluid, the left side can't clear it out, there's lots coming in, where's it going to back up? In the lungs. Okay? So, there was a time where all cardiac patients, we minimized the amount of fluid we gave them because there was this concern for heart failure and then pulmonary edema secondary to fluid overload. I don't want you to panic about any of that. In certain cases, they absolutely need a lot of fluid. So you don't have that diagnostic capability, but if you really want to, the right-sided heart attack, if the right ventricle is what's involved and is failing, it needs fluid desperately. So 2 or 3 liters of fluid on a right-sided MI is not inappropriate. Don't take a note and don't you dare do it. But from a really advanced level, what we want to be able to do is provide a lot of fluid coming back to the heart. So if they're low volume and having right-sided failure, that muscle needs fluid to get stretched. It's called Sterling's law, all sorts of, but it needs fluid to be stretched. So just being appropriate, giving them the appropriate amount of fluids. If they're hypotensive, give them a little bit to see if we can get that back up a little bit. Maybe we get some lowering heart rates. So anyways, cardiac patients used to be all that, but fluid overload is a risk or is a potential complication. So we don't just everybody wide open, give them a liter of fluid. It has to be measured what we want to do. So give them a little bit. Sometimes it's give them 200, recheck them. Give them 200, recheck them. Give them 200, recheck them. However you guys want to kind of go down that route. So That's how we ended up. I think that's what we're kind of doing at Dodge right now too. Give them 200-300. If I know somebody's really dehydrated, it's a heat exhaustion, I'll give them 500 real quick and then slow that back down. Any of those things, but not just, whoop, oh, now I'm done. We still have to reassess. Keep checking the site, listen to lung sounds, record your vitals, especially if they're sick enough that you're doing fluid. Q, how often? How often do you want to do? About every 5. So critical patients are 5. Yeah, it sometimes turns into 7 when you're so busy, but more frequent for that, stable, 15's fine. So if you want to split the middle and go 10 on every patient, you'll be a little late and a little early, so who cares? So, and I don't know, do you guys have your monitor also does your BPs and stuff? So ours are defaulted to 10, so we cover both bases on our automatics, but I'll throw an extra one in there from time to time. Okay, I think that's all the pieces. What else do I have? I think we covered all the pieces. So who can do it, what we're going to do, kind of showed you we're going to play with that some more, when we can do it, how we're playing with still, where, whichever environment, and when. We already talked about that. So good. All right, so now we can start playing a little bit. So you did talk about on the body, so you have cephalic and basilar veins are the big ones. You know anatomy, right? Okay. Yeah, I looked this morning. That's the only reason I remembered. So, one other complication or potential risk, which is a normal variant, you can miss the vein or go through the vein and actually get an artery sometimes too. It's very rare, but it does happen. So I've seen it twice. My one partner, she was like the ultimate perfectionist, and she did the IV and we're doing this, and we look back and bright red blood's working its way back up the tubing, and oh my God, I'm getting fire. I'm going, no, it's totally normal. So we squeezed the bag a little bit. We closed that one off and started one in another place. No big deal. We just had an arterial line. All right, no big deal. It's not the end of the world. Just realize that if you pull that out, now you're gonna have to put some pretty good pressure on it. No, she ended up hitting the radial artery. So anyway, kind of funny. Or maybe it was brachial. Either way, I can't remember which one. But yeah, we got blood going back up the tubing. It's like, whoa, okay, that was kind of different. All right, so yes, that theory is we generally start low and work your way up. Because the theory being I poke a big hole up here and I don't get it, so I start back down here, stuff might leak out this hole upstream as it's going back up. There again, yes, that's the principle. However, I get this one and I don't get it and I need this line, I'm still sometimes, I'll see if I can go someplace else. But in principle, start low, work your way up. My favorite routine IV spot, so you can look at a lot of different anatomy, but on the back of the hand, sometimes you got these nice little tendons running through, they can throw you off, but usually someplace between the ring finger and the pinky over on that side, you can usually, there's one that kind of bifurcates right there. I like going right straight up because it doesn't wiggle on me. So I don't remember if that one's kind of right in here. But whatever one shows up is going to be your bet. Couple things on vein anatomy. What's the difference between an artery and a vein, first of all?
Arteries go to the heart, blood, veins take it away.
Arteries away, veins too, yes. Aorta's the heart. So usually the answer is oxygenated versus deoxygenated, but you guys have the right definition, so I'm going with that. The arteries are high pressure, much more muscular. They're the high pressure side of the things for the fire guys in here. The veins are more of the drafting, and we're trying to pump, supply. Anyway, one of the other structures in the veins that the arteries don't have is valves. So inside the veins you have some valves that kind of protect backflow. So it's under more of a, that's a check valve to keep stuff from going the wrong direction, because you got the left side's pumping out just fine, but as it's kind of working its way back, you don't want it to backflow, so there's some veins. Occasionally, when you're looking at people's arms or you're looking at their veins, you'll see little bumps or nodules or little, so there can be veins that are kind of prominent. Occasionally when you're trying to put your catheter in, occasionally you could bump up against a vein, or excuse me, against a valve, and you won't get much of a flow because it's not enough pressure to get through and open that back up again, or it's pushed right up against the tissue of the valve itself. So that's another, it's not a complication, it's just something that that you can get into trouble with, or it just won't flow.
The other day, and I had to squeeze the bag
Yep.
to force it open.
Right. And so occasionally, once you get the flow going, then it's fine. But sometimes being able to thread, so you'll poke in here and you'll start to advance and all of a sudden it'll stop. So you may have popped through the other side and you're going into tissue, maybe you're in the lumen, but now you're up against a valve and you can't get it to float past the valve. So sometimes you can do what's called floating it in. You can hook it up to your solution, or you can use a flush if you have them. You guys don't have those now, but you can float through there sometimes. So it's, if you can't advance, don't force anything, but if you're almost there and you're already hooked up, maybe you can float it in. Early on, I don't know that I would suggest that. If you can't get a clean advance, just start over, try a different spot. Okay, so that was one of the other complications. Now that's a little more informal. Any questions, concerns, thoughts?
Well, I give blood, and
Mhm.
they struggle every time. So
They
what
don't
if
want
we-
it.
What if we have, and he's like, anyway, but they really, really struggle. What if we run
Okay.
across that in?
So there's a couple of techniques you can use to help veins pop out, or in certain circumstances. So one is get the tourniquet on and get the extremity lower. So you got gravity working for you. So have them hang it over the edge of the cot. Sometimes you can do a warm pack, or just hold your hand on it to warm things up. That'll help. Another one is you can just tap and irritate the hell out of it. Yep. So
You irritate me.
So working back off of this. So there's a number of veins that work on here, and I can bring up the chart, but you can see them just as well as I can. So as much as seeing, but feeling is both the how to decide where to go. So for me, nice soft spongy, oh, I can feel that. Yep, I can see it, and great. So put the tourniquet on. Yeah, so you put a tourniquet on. Now, depending, and there again, if you're really trying to isolate here, instead of trying to get the whole arm, if you're really struggling, put it down low and just see if we can get that hand to pop. My favorites are kind of right in through here, occasionally there, and then somebody called this the intern's vein at one point or another, but there's one that runs right along the inside of the wrist. Well, yeah, that's really is, but there's one here, and I can't remember what this actual one is, but occasionally this pops up pretty well. Does she have a pretty good one on her wrist there?
She has a question.
Yeah.
Is there a place where you should not do it? Should you not do it in the middle of like your hand? Should you not do it on your palm?
So palms generally no. There's really nothing there to do. Forearms will hurt more probably, and they tend to run a little deeper. However, any port in a storm, if you can see it and you can feel it, so now your forearms, they kind of wrap around nice. I mean, Jesus. Yeah, I mean, you could, yeah, heat seeker from over here, you can dart it from there, but so that will work. You can go farther up. One of the pieces is right here where you've got a bend. It gets to be a little tricky, because if you start here and then now they're bending their wrist, it becomes somewhat positional, and it can kink off that catheter. Same thing up here can happen. So if we're dropping it in here and then they bend their arm all the way up, you might bend that catheter and now you don't have a flow. Excuse me. So you'll have to keep their arm out. It's what we call a positional IV. If you really need to, you might have to splint that so that it stays in the position you want. More often I've seen that, especially in the backs, when you're doing hands and they're very tiny veins and they're fragile and you don't want them to move anymore, you could do almost like a wrist splint where you put the gauze in their hand, put a small board splint and kind of wrap it up, leaving the part where it's actually the catheter is in right around so you can see for swelling. Sometimes that'll work. Pediatric patients that are picking and moving, that might also be a solution for you. And they do, yeah. So you could do that. For the number that you're going to be doing and the patient load that you're going to have, it's probably not worth worrying about. It's something to consider, but so somewhere along here, occasionally you'll find some up in here, but hand and AC are going to be your go-tos. You're not allowed to do EJs here, I'm guessing. Can't do external jugular. Do you have a prohibition on feet?
No.
Okay.
I was actually thinking about that.
So there are occasions, I've done about 5 of them over the years, where they were either mangled up or I just couldn't find anything, but man, I looked down at that foot and I went, oh my God. And again, it's not because I could, but I needed one, and that was what I had, and it worked. So just consider those other things. Just because it's there, This is those patients that you're waiting for that chopper to land and they're going to be at RS, whatever. And that's there and that's your only shot, go for it. Absolutely. So scalp veins are probably not cool. So, but you can do them. You can't do them, but they can be done. But you basically have to put a tourniquet all the way around and then, yeah. And no. Much easier on people like me than nice big curly over here. So yeah, my R and SPF have dropped way down over the years. So that's all right. Part of that technique is going to be, so once you're ready to find your spot, so we're going to turn the gun on, we're going to get it all cleaned, and then when you find it, one of the techniques you're going to want to end up doing, so let's just use this big one here for a second, is you want to control or stabilize that vein. And so how you do that, so if I was going right here, I'm going to put my thumb here and kind of pull a little traction on it to keep it from shifting and moving, because if you just leave it, it might try and snake around. There's different schools of thought. So you're either going on top of and straight in, or sometimes coming in slightly from the side and going that way. Going from the side, if it runs away from you, you're just going to chase it and it's going to stop eventually and you go in. If you're going straight over the top of it, it might sneak off to the side or the, so for me, one of the things I've seen new IV folks doing, and again, it's a preference thing, but for me, is I'm visualizing going all the way into the vein on my first strike. What I see is being very tentative and going super slow, and you're slicing into the skin and then finally into the vein. I'm going, God, that's gotta hurt that poor patient. So for me, I'm going through the skin and hopefully into the vein. If I don't get flash right away, or if I don't feel that slight pop when I go in, then I'll go, just a little more. Now I got it, flatten it slightly, finish up by pushing in the catheter, then retract, and then retract, okay? But either on top or the side, it's a preference, and it's just kind of something you get used to and figure out which one works for you. But that's part of why I like, he has a great example up here. You almost have a trifurcation there, but by going, I kind of go up in between, go up the Y, and it can't go, I'm right, perfect. It doesn't move on me. Once I get through, no, it's just a wall there. So, in any case, that's just me. It's one of the ones I've done. Otherwise, again, if you're really, really, most people, you've got one running across here, you got another one over here, and if you can even sort of feel it, and you have to get it, you can kind of, if you know about where it's at, you go, well, I can't see it, but I can sort of feel it. So what I end up kind of doing, so like on mine, I will actually take my nail and get a little bit of a line about where I think it is, clean it one more time, and you can see just a little bit of that mark left behind, and I just go in there and fish a little bit. Mostly on those, I have to have it kind of IVs. So don't be doing that on most people, but it's another technique. Is once you have a sharps out and about, especially if it's been put in anybody, now we don't want to have a needle stick with somebody else's blood on it. So icky yours. So once that's there, everybody else needs to be staying out of the way. If we're going to be handling needles, it goes into a sharps once you're done with it. And that's our simple sharps. This is going to be retracted, and we'll play with that a little bit. But the other thing is to not recap needles. Once you've opened them, you don't want to recap, because you run that risk of doing that. So we did that, so we'll do one more just to make sure we're super clean. And impure thoughts even. Okay, those are all good. All right. Ta-da. All right, so now we're live. So I do my little bit of break the seal kind of thing. There's a little tab on there. So
It's so fun when people
So when
are
you
watching.
say breaking the seal,
So just here, I'm just twisting that hub a little bit.
thank
That's
you.
so if it's kind of stuck on itself.
Got it.
And this tab kind of helps me steer it. So this goes this way, and I keep back pressure on that tab while I'm going in. These are going to put this is keeping back pressure, and I can push the whole assembly in. Then I take my finger on the other side of the tab and advance it. So let me see if I got it. So if I'm going here, I don't want to get down on my thumb, so I got to have my thumb down far enough. Ooh, this lighting is really fun. Okay. All right. Boy, that's running away on me. Why is that? Oop, did I miss? What the hell? Oh, I'm there. We got it. Come on. Okay, so I'm back out. Oop. There we go. Retract that. So if you can look in that flash chamber, you see the blood. He got so much in there so fast I didn't realize it was in there. So that, yep. Somebody to help me with that. No, grab the other plastic right there. Just hold it and I'll spin it off. Let's see if I screwed this up. Nope, we got blood flowing back in, so that's good. All right, so you want to hold that up and run it.
That's the driver.
Oh, here's driver.
Oh, boy.
Okay,
EMR/driver.
is it running? Keep going. All right, so now,
How do you feel, Evan?
I gotta pee.
well, let's run that whole liter in just for the heck of it.
Yeah, I think.
All right, so now,
Lock the bathroom.
either I can do this or my partner can, but
Can we have hold it?
with these, I do it over both the hub and the lure lock. Then we can take the rest of this off. And we're looking for swelling upstream, so we're pouring it pretty good in there. Let's just run a little bit in just to
Okay.
make sure I didn't blow it. Oh my God, we're giving an air embolism. So look upstream, you're seeing all that up in there? Are you digging for life insurance? Is that what she said?
No, it's fine.
Oh. It's all right.
It's a group.
Wow.
Okay. So now if you look at this, we got that 18 in there. We're getting a pretty good flow going. We've already got,
She's pouring.
we've got almost 100 in
Are you
there.
dehydrated? Have you drank any water today?
No, I had like 6 Pepsis though.
Oh.
Oh, yeah,
Okay.
that's good for you.
So
Brush your teeth.
if we do
I
a,
had a single one.
So wherever this is gonna determine
Yep.
the drip rate, not necessarily, I suppose it's both, and the flow rate.
but, so your drip rate right now is 0
0.
drops per second.
Okay.
So if we do about a 1 drop per second, let me see, roll this up here. So 1,000, 2,000, so about
Okay.
1 drip a second is going to be, so about 6 mils a minute, or whatever that works out to be. So if I do 1 drop a second, is 60 drops, which is going to be, yeah, exactly, 6 mils a minute, which is going to give me,
And you tape it down both because you don't wanna accidentally rip it out.
right. So this is just holding that in there, but we're keeping the space around it so we can still see if it's swelling or bleeding or anything else. So then I usually do 1 kind of across here. And then I usually do a second one upstream, or up there. So a couple of different ways you can do it, but this is my second one. So I'll try and do 2 so that if we yank one, that's a safety, so this first one doesn't come off right away, so it becomes my second kind of a safety for me. So there's other ways of doing this. I'll show you again when we're running it. So, all right.
Wow.
So there's 100 mils in already. Well, we can run the whole thing in for you. You'll feel better. So now, if for some reason you really want to get it in there, can you feel like
Yeah,
you feel a little bit of cold, kind of cold?
Well, it feels cold.
Yep. All right, so we're really pushing some stuff in there. So now, when you start to do IOs, pressure bags are pretty important for that because the marrow. Usually you don't need to, but the pressure bag has got a sleeve and it's kind of like a BP cuff bladder on it, and it'll squeeze on there pretty much. But for the most part, if you really need to get them a quick little bit, there, we're close to 200 already, 150.
There'd be no reason that we would take it out, right?
No, once we put it in, we
It doesn't,
leave
it
it.
doesn't get touched.
Usually.
Okay.
Oh, see? Oh, hey, there we go.
What's that? That's
Okay,
blood.
that's blood.
Oh my God, I must have screwed it up because we put gravity the wrong way.
There we go. Yep.
I'm
So-
kind of glad you did that. I
Yep.
was like, wow.
Do it
I
again.
saw that with,
Well, I mean-
Joey,
Going to
yeah.
the hospital sometimes, so they just
And
throw the
that's why
bag
you
out.
always have it up.
You do. But for just a little bit, so you got it hanging either up on your IV thing or on the IV pull on your cot, right? So now, just before we go in, maybe we don't have a good place to put it on there, or maybe we're transferring them over to the helicopter. So for just a minute, we turn it into a very large saline lock,
No.
and it's not going anywhere because it's completely shut down. Just for the transfer, and then we bring it back up and start it back up. Or if you're handing off, then, hey, it's locked off. Okay, great.
So our cots have poles on them,
Yeah.
and then there's hooks in the ceiling of the truck.
Yep. So,
We have Velcro on those hooks too that you can use to squeeze
Like
the
you
bags.
said, when we switch from our cot over to the helicopter cot.
Right,
A lot of
or-
times it gets laid between their legs.
just for that, for minutes, but just,
Until it
so
can
that's
get
all
reset
part of
up
that
again.
crew resource management and that idea of clear communication. So, okay, I'm clamping this off, great, clamped off, so now they know that it's clamped off and they're ready to go again, okay? So, stupid pet tricks as long as I'm sitting here. If for some strange, crazy reason we set this all up and we go, oh my God, there's air in the line all the way down, there is a little trick you could do, and that would be, is you can basically pinch this off and you can draw air out with a syringe and pull it out, but just do it the right way the first place, you're good. Other than that, that little bit of blood in here is no big deal. That's no big deal there. So, all right. So where you might want to take it out is if you infiltrated, you might want to pull that back out, or if we've started it and then poof, then we're going to pull it out. And so I'll show you.
That'd be the only time we
Right.
take it out.
But usually, once it's in, even if you infiltrated, you may just clamp it off and say, hey, that one blew, we just clamped it off. So that's up to you guys. I'll do that, I'll do this, but I'll show you how to take it out. It's not that big a deal.
You can take that home as a souvenir.
I will.
What do we have to clamp it off with?
Clamp what off with?
When you say,
Use the
With
blue
the
plier.
roller, with the blue
oh,
roller.
and just leave the whole line?
Yep.
Oh,
See, it's all there. So we were talking a little bit about maybe you guys want to add in an extension set so you can then just
Yeah.
have it be a lock instead. But
That's
let's
what I was
let's get through one step at a time first. So this,
Definitely sticks good, doesn't it?
sorry about that, buddy.
I can rip it off.
Silver Fox Safety and Day Spa waxing. So. Some people pay good money for that, you know.
There you go, Karen. I can have a side profession.
We're so tired. So
Okay,
Sugar.
so I got most of that up and ready to go.
Hot yet?
Just use it, Karen.
Well, yes, thank you. All right,
Karen,
okay. So here's your a 2x2, and you're ready. 1, 2, 3. Okay. So you want to keep pressure on it?
Yeah.
You okay with that? Okay. So I did not sharps this. Do you have a big sharps, or do you want to just do this one for
throw it in
now?
there for now.
For now.
Clean it up later.
Okay. So that's in there. This is just bloody stuff, so we'll.
Just a regular biohazard.
Yeah, really. Two more things. One, at least from a crew resource management, every place I've been, we will clarify once the sharps is gone. So I'll either say sharps is on the bench, or sharps is on the counter, or sharps is away, so that the rest of your crew knows that. Or if I do a line, you're driving for me, and hey, drop sharps is away. You still be careful putting your truck back together and cleaning it up, because you forget from time to time, but just that one little cross check of, hey, I already got rid of the sharps, so I'm good. Try very hard not to hand another sharps to somebody else. It does happen, but be super, super communicative about it. It's probably better to set it down. Now you take the next and take over, so you're not getting that out of there. Because the needle stick is a big deal. Lots of paperwork. Your immediate risk is still pretty low. Yep. So, so there's that. As far as documentation goes, when you're doing that, it's up to you guys how you're going to do it. In my experience, it is each attempt, there's only one attempt. So some charting systems will say how many attempts, because some places only want to know how many it took to finally get it. And my problem is okay, so that time that I documented, is that the time I finally established it, or was that the time that I started, and how long did it take me to get? So my advice is each attempt gets its own time and attempt, and it's either successful or unsuccessful, period. If you do a new attempt, it's a new attempt, so you should only have that field be on number 1, because they're always a 1. So that attempt is going to either be successful or unsuccessful. Then you document size, location, and then if there's a solution, what solution you used and how much you're given. In my, what are you using for charting? Are you using the States Elite? Okay. So in there, it'll say, so you'll have a procedure IV, so initiating an IV, and then a medication, normal saline. Okay, and there, the normal saline is the dose, in that usually that I enter as total dose in. If you were to give it as boluses, that's up to you guys how you want to do it. I would clarify that probably in the narrative. I'd want to be able to deliver the total dose by the end of that result, because when I finish my chart out, that should total. When I hand off to you as the nurse in the ER, I want to be able to say, this is my first liter, I'm about 700 in. So when I chart 700, I hand it off 700, so that they're not coming back, well, they fluid overloaded them because they didn't know where I was at. Or I only put 100 in and I've documented 100, and well, they didn't keep control of it and they ran a whole liter in. I ended at this, that's how I ended up. It doesn't happen, but that's what I'm doing.
Yeah, so make sure that you're only documenting how much is left when they take responsibility of the patient.
So
So
if there's
do 100 in, that's
great,
go.
put just 100, that's fine. You could put down, we hung a liter bag, but only administered a whatever, however you want to do that. I don't even bother with that part. So attempt is either successful or unsuccessful. If it's successful, where, what size catheter, and then any medication or solution that you used, okay? And then your reassessments, your vital signs. So if you initiated it at 2015, you probably want to have another set of vitals at about 2020, and then depending on how critical they are, probably another second set of at least documented lung sounds someplace within that 15 minutes that you at least reassessed, or at least clarified it in a narrative that lung sounds remained clear throughout the remainder of transport, something that you are looking at that lung sounds, because there are those implications. So if you have a hypotensive, dehydrated patient, whatever else, that you think is a closed container hypotension, and you're seeing the stereotypical tachycardias, you're in the 120s or the 1-teens, and their respirations are 26, and their pressures are 92 over 40, we see their pressure go to 100 over 48, but what we see better is we're going to see the heart rate come down to the 106 or 104. That's going to give us an even better indicator of blood pressure. If we're starting to see that come down, I'm okay with that pressure then. If we can get that heart rate back out, that's that permissive hypotension as well. So bad traumas where we have an open container where we're bleeding somewhere, if they're really bad on pressure, sub 90, sub 80, just get them back to 80. Just get them back to 85, 90. We don't want to blow clots out, but we might need just a little bit of support, that kind of thing. Anyway, but that's your documentation side of that, is talk about when you initiated it. And for me, that attempt was when I poked the skin. So for me, I hold it like this, and then that tab, so
Okay.
break it, pulling back pressure with that one,
Yep.
kind of pushing, so it's keeping this whole assembly together.
Okay.
And then your thumbs here, where do you want to hit?
I want to hit like here.
Okay, so just be sure we're going to come from the side,
Okay.
or enough angle so that we're not going across your really nicely painted nails there.
Okay.
So push forward on the green tab.
Forward on the green tab.
Mm-hmm.
Oh.
So push forward on the green tab.
Oh.
You're pulling back on the
Yeah, the
needle.
needles. Yeah, you're pulling.
See, you screwed it up. Go ahead and now hit the white button to get that needle out of the way. There you go. We'll grab a new needle.
Getting that heat, your angle comes way down, but you're still, you have this on, right?
See, sorry, I wasn't, that was perfect.
It was A+, I would say.
Except for tamponading off.
Yeah. Okay, so if you forget to do that, it
Blood.
just could, it's
Blood's gonna start pouring out.
Okay.
It'll remind you.
Yeah, I'll see it once.
Yes,
and-
yeah.
Okay.
So,
That keeps my.
Oh,
So-
stop. I'm trying to hold it.
honestly, in the Chuck's idea isn't bad
Yeah.
to lay, or if you've got them on the cot anyway, by having a blanket on over the where you're doing it,
Okay.
kind of helps with that a little bit.
So I'm holding pressure here.
Yep.
And
Then
the
you're gonna-
reason I'm doing it is because
You want to keep.
I'm gonna make it.
Yep, you're gonna make it a bigger mess at this point.
Okay.
So,
I'm
because
holding
we're keeping the blood from flowing in, you want to hook up.
Get that in there.
Yep. So when you're holding it, so if you do,
Gives you an idea, it just gives you a visual.
so if you do this with, so you just did this.
Yep.
If you pinch the hub and then take these fingers,
Yep.
you can use these two fingers upstream.
Okay.
Those two fingers are tamponading,
Okay.
while you then remove that and then you hook your other one in.
Okay. Okay.
It's a lot of practice. Okay. Give her a shot.
Right, so he was.
Now, the easiest way to do a tourniquet,
That's what I want to mess with.
you should put it
You
on.
want to?
Great.
To remember
There you go. That's really close. Yep, that's
Okay.
perfect. So that's usually how I do it. So if we're gonna go all the way up here, so in, up, oh, sorry,
Into my personal stash.
and then Jen, just that.
Okay.
I didn't mean that out loud, sir.
The thing that's all folded up in your.
Okay, then I have,
You got a question or you got it?
I want that.
Yep. I can get you another one.
I'm a girl from A to B, or A to Z.
Nope, that's totally fine. Okay, so let's do a whole your whole
Yeah,
setup.
that's what I want.
There's
Exactly.
all
what I
your
want.
stuff.
Alright, so, Tegaderm.
And if you really want to have some fun, you want to do this part too? Okay, do the whole thing. So if I'm doing without Tegaderm, then I'll do 4 of those.
Oh, okay. Sure.
I'll show you the there's a little butterfly technique I use if I don't have a Tegaderm.
I feel like that's what they do when we donate blood.
Could
They
be.
don't want the whole
Yep.
setup because
Yep.
it's coming off.
Okay, so let's grab your IV. Why don't you grab your bag first, make sure it's ready. What are you looking at? So it's good. The other thing is look at the solution. It should be clear and not cloudy. And so as you take that off, it's easier to see through. So again, it's not like yellowed or you see floaties or anything. You don't see any floaties in there. Good, okay, perfect. So something like this. So I still got the tension. We can just tuck it under there a little bit. Doesn't have to be perfect, but at least there's enough. Trust me, you just have to do it a lot. So one of the pieces here tonight is you need a more supervised time before you're really doing it. 'Cause
Nope, I have
you're doing great.
gloves
Your gloves are on. Have you wiped off your stuff? I saw that, I guess. So that's ready to go.
I'd like to know who did it. I'd like to thank you.
So this is close. Your tape is over here. Okay. All right. Oh, you just touched every place that you just touched.
I know.
Yeah, there you go again. Okay, so keep that anchored. Where are you trying to hit?
So I'm gonna go like right.
You're trying to go up this one here?
Finger up on this notch, this finger, put it up
So
there.
put that there. And, yep,
Yeah.
but pulling back. So go on the
Yes,
there.
yes, yes,
There you go.
yes.
Because if you push on that, you're good.
Advancing the catheter.
Then you advance the catheter and everything goes back. So go through, feel the pop. Okay,
Yep,
there you
now I
go.
do.
Now,
Yep.
now go on the back side of the tab and push with this finger while holding these steady. Push that forward. There you go, there you go, there you go. Now,
Take that thumb and put it over there.
you could do that, or if you want, try this. Grab your hub, take these fingers and push on the vein.
Oh, that's awkward.
It is awkward, but, or, there you go. Now pull these 2 fingers back, or do that. So otherwise what you can do is, while you're in, you pushed.
Yeah.
So, yeah, I guess you did that right. So you're pulling back with that, and then go ahead and hit the white button if you want to make that go backwards. There you go, that's gone. So you're tamponading that off, and here's your, I'm going to let you do everything. Oop, now you touched the end, so that's
I got
bad.
gloves on.
Doesn't matter, your gloves aren't sterile.
Okay.
There you go. Okay, so you're in, and then,
Hopefully.
yep.
Oh yes.
Put it in your hand,
Oh, but it's not really straight.
right?
I think you're in.
Now you're gonna pull tension and hold it.
Okay.
Pull tension and hold it. Because now,
Okay.
when you're done,
So the thing is, oh, yep, it's working.
Okay.
I put some pressure in and it's pushing back, but don't let go of this
Don't
until,
let go.
and you're not, here, look at your hub. Oh yeah, you're fine, my fault, you're good.
don't let go.
But so just don't let go of that
right?
while you're getting this ready. So that's why you have it prepped.
Yeah. Okay.
Okay, go ahead.
You said to go on.
I usually go over the hub and the, something like that. There you go. So there you go.
Right. Good question.
I'm gonna need more needles, I promise.
So you can do that one, that's fine. So what you could do
Oh
though,
yeah, you. You said-
Just
you
going to
said
show
that.
you. But so you did it that way. So
Yeah.
do it again.
Right,
Yeah, okay, I'll see you
They have all sorts of
tomorrow.
because then you came back.
And then a lot of times I'll go farther up somewhere and come across here. Yep. Because that gives me just one more. So if I yank the tubing, it's just one more pigtail breakaway, so I'm not yanking this straight out.
Okay,
So,
this is fun.
oh yeah.
So I'll see them when they wrap the tape. They'll do around it
Yep.
Oh, yeah.
So-
for that one, so that when they tape it down,
Yep.
this doesn't slide at all.
Yep. That's another way of doing it. And so I do the same
Otherwise,
thing.
you just have surface on the top of your.
So you could do this then too, because I do that except when I don't have this. But this is not bad. That's a really, really good idea because now you've got
You've
grip.
got tape all the way around.
360
the hole,
around the whole.
on that top
Yep,
surface.
that's spectacular. And now you add another one in up here as a safety.
Sure.
Yep, because it's
Yep.
harder to pull that out.
That's brilliant. I'm going to start doing that.
I watch the paramedics do it all the time.
I'll-
Every time I see them do that, they
Yep.
wrap it around it and then.
Right, because so for me, when I first started, we didn't have the Tegaderm, so I would
Right.
that very same concept. So, oh shoot, here, where's
Because
that
that's
tape?
putting the back pressure on that. It's not.
Yeah, sure.
It takes more to rip it off. Except some of our cases, it's pretty easy.
Yeah, it does. So, but I do that exact technique. So before the days of the Tegaderm, I did the very same thing. So, here. So yeah, I would start with it up.
Again, you're trying to do this one-handed and stuff. And
So,
Oh,
so I would do
yep,
this,
and then tape it
that,
down.
Yep.
Sure.
and that was old school up over the hub I was pulling out. But
Yeah.
that, and then another one, and then another one, and then another one, and whatever. But the Tegaderm, I get a lot better.
Yeah. Super.
So, yep, there you go.
All right.
Theoretically, we're not like cutting off shirts and doing stuff like that, depending on, but when we're starting an IV and we're now connected to all of this, are you disrobing somebody before?
So there again. So you got me. I'm a little low on my sugar. You're not entirely sure my pump's working right. I'm gonna give him an IV because I think we might need to.
Yep.
Great. So I got my shirt on. Go ahead and start it. If for some reason, great, it's all there, no problem. We get to the hospital and they want to get me into a gown.
Yeah.
They just clamp it off and they feed it up and then we just take it all off. We don't have to cut. It's just totally
That's
normal.
not gonna be, okay.
You have somebody that's got a horrible arm fracture or they're whatever, just same rules we would need to get access, we would use if we get access.
Yeah, okay.
So there again, you get the little old lady with the hip pain. Don't you dare cut my, okay, well, we'll do our best and
Yeah.
whatever.
Yeah.
So,
Okay.
but if you need to cut away.
Right, okay.
So you get that critical
It was
one,
just one of those
absolutely.
things I was laying awake thinking about last.
You spent the $90 on the drafters, you might as well use the damn things. Two philosophical things for me is, well, I'm just going to wait because we're just around the corner from the ER and it's still clinically indicated. It's still our responsibility. We're well, I'll just let the nurses do it. That's copping out. Now, if it's truly, no, I don't want them to be stuck more than once, that's a game plan, that's different. Because it's the only way you do get good is to keep trying and practicing. So if you look and go, oh, I can't get that, it looks too squiggly. Well, I'll throw another slight twist at you. Occasionally, especially little old ladies with fragile veins, sometimes not using a tourniquet because we put too much pressure in there, but that's a unique situation.
Now, Joey?
That's one not doing, you scared me.
Get everything else under control, then introduce the Narcan. Get that breathing under control, get all of that done first. We get way too hung up. Too many sort of systems or too many people with that new toy think it's the cures everything. Yep.
If you pop that, you give that, they're gonna come up and then they'll be agitated, combative.
Yep. Or it wasn't an opioid overdose and we're expecting it to fix it and they're still not breathing. Now we're 5 minutes into it and why isn't this working? Why isn't this working? If you don't need to bag them, you don't need to Narcan them. And if you do need to Narcan them and you're bagging them, you don't really need to Narcan them. Because you're solving the problem. The problem's the respiratory arrest or respiratory depression, and we can manage that.
He had socked the bottle away.
Just saying. Just saying. And with it, what we've got now is you have the single blast 4 milligram ones. You're hitting them hard. Now, granted, if they're doing some carfentanil or something over the top, they may need that 4. If they're just sort of out and we give them 4, we can give them to start puking, or sometimes diarrhea is another one. Occasionally they might come up combative or whatever. So in the real grand scheme of things, solve the airway issue, you're fine. You could manage an opioid overdose all day with not one bit of naloxone. So get that all under control first, then we add in the Narcan if you need to. That's my theory on it. So the other one that we'll talk about a little bit again too is, and I'll pick on the cops here a little bit, but the DOJ has been pushing and pushing and pushing that fentanyl is the most deadly thing on the planet. If you even see it, you're going to die. It's nearly impossible to have an incidental fentanyl overdose. It's nearly impossible. There's 2 toxicology groups that are out there. Just seeing it is not enough. You have to actually inject it or snort it or whatever. So even if you get it on your skin, no big deal. So they've really got a lot of people afraid over it. And so certainly wear your gloves, do all that other stuff. But there's a number of high-profile cop events where they had an overdose. It was an anxiety reaction, absolute panic. So they think, because the DOJ has been pushing us so hard, these poor cops are walking in and they think they're going to die, and they go, and it's not the time to tell them that's what it is. Well, we gave them Narcan. You could have sprayed beer up their nose; it would have done the same thing. So we're trying to dispel that, because if it was really that deadly, the dealers, the families, the public would all be dropping. Absolutely. So now, if you throw a flashbang into a frickin' production facility, that's different. But you know,
You can still take it upside down and it's not gonna go anywhere.
once it's open though, it gets kind of interesting. I've done that more than once too, when I'm going to change bags and it's like, whoosh, the last 200 mils flops out of my leg, but oops. You got it?
Push and twist.
There you go.
There you go.
Look at that. Boy, we're blowing through your supply budget in one night. I like it. There you go. That's most of your bubbles out. There you go.
Comfortable with that.
Good. And there again, if you're single, I would loosen that and then put it back.
Just so it's barely on.
Just so it's barely on. Because otherwise,
I'm gonna do that.
yep. So, just enough so it's on. Yep.
Just to keep it clean.
Yep.
Now I can put my tourniquet on and then I'm gonna go.
Okay.
Should I spec it out now already?
If you can do it without the tourniquet, that's great. But there's a small subset that the tourniquet makes it worse. I don't want to speak for this gentleman here, but my guess is that for the most part, try and have somebody that's done one before or is familiar with it, just to have that coaching. If you're alone and you guys are, and it has to happen, I'm guessing use
If you need it
use your best judgment.
and you see it and you feel comfortable, try it.
Okay. So,
If they need the fluids in a situation,
but
Well, it's the 15 steps
but
before it that I don't want to mess with.
but
it becomes
Yeah.
once you get doing it more often, it really does help. Now, if you have access to, so if you work in other parts of healthcare and you had an opportunity to maybe tag along with an IV team, or if you do ride-alongs or you work in a different service, great, you have more opportunities to do that. If nothing else, just to watch a few more.
Okay.
But you can do a lot of videos, but the only way you do it is just to do it.
no.
But
Now you just name my finger because you didn't
clean off your glove first.
You didn't clean
Yeah.
your finger.
Yeah, you're right.
There's extras on the side of the kit there.
Yep.
So now you gotta re-cleanse myself.
So this is really cool, but it is not trivial. There are implications for a lot of this stuff. So this is not just a, oh, hey, I know how to do this. It's a lot to it. So, but you guys are all doing very well at taking it seriously. So I'm very comfortable.
Now typically what I do is my non-dominant hand to clean, to feel around.
Mm-hmm.
Okay.
Yep.
And now I'm gonna go,
As do I. Same situation.
I think this guy.
Yep.
Okay.
So just make sure your left thumb is far enough downrange, but still able to do it, that you're not going to contaminate your needle.
Okay. So I'm gonna take this off now.
Yep.
Doesn't take much.
Just a little. That's all you need.
One screen this time.
Yeah, but.
Oh.
Now you need a new needle.
Yep.
Do I?
Yep. Look at your catheter. Where's your catheter and where's your bevel? It's inside the catheter already.
Oh, that's what you talked about. Yep.
So here, I'll show
Okay.
you. I'll show you
How come
the.
that happened?
So
Maybe
because so. All right, let's get this back to where it should be. Okay, so these two are holding solid. This one holds back. But if you're not, if you're punching around, see what happened? It already came off the top. So I'll take the extreme of that, and now we try and pull it back on.
And then there's plastic in
That's
there.
what you're talking about, the plastic, okay.
That's catheter shear. That's
I
an,
really don't want that floating around in my.
and that's a real exaggerated example. But even a little piece can be dangerous. Yep, can be dangerous. Clear.
Look at Joey's fingers.
No, you have to turn it down real nicely.
Hey, Andrew, before, like he told Paul, sit.
You can do that.
And
Yep.
it seemed to go.
Yeah.
Yep. Looks like your catheter is still okay. Yep. Okay.
Okay.
I think it is. I can't see very well. Little more angle. There you go. Go quick.
Center of gravity.
What else are you guys think, what other natural disaster could they possibly have?
There's his vein. So come back over this way.
Okay. Are you doing okay, Joey?
Keep coming. You're off quite a bit.
Okay. What should I do?
So you are right there. His vein is right here. Move this thumb. Let go. There. Now go.
Now go?
Try and keep going with your needle.
Okay. Are you doing okay, Joey?
I'm fine.
Keep going. There. Now advance. Advance your catheter. There you
This
go.
is, okay.
I don't know if we went through
I'm
or
gonna
not.
stand up
Go ahead.
Want to be?
Now. Get that under control.
so I can,
Get that under control and tamping out at the same time, however you want to do it.
Pull back and then hit the button.
Pull back, hit the button. Keep going, keep going.
Those things were
Button.
Button.
yeah, I'm trying.
No, it's on top.
Yeah.
Oh, she spun it around. There it is, right there. Push, there you go, straight down. So,
Okay.
And now you want your tubing.
They just,
Thank you, John.
you leaving me?
Yeah, I got kids.
Oh
so
my
I
God.
have a soccer team.
I got none that I know of, but you know, I got
Thank you,
5,
yes.
so.
Thanks, Joey.
See
Bye,
ya.
guys. See ya.
see you later.
I can release my left hand.
Just as long as one hand is always in control of that line.
Yeah.
So as long, this one's under control, good.
Okay.
Now pop that.
That's why I keep it in the car.
Now lift that.
I'll be your IV pole.
Okay. Now I'm gonna open it and make sure.
Hopefully we made it instead of bounced off the side. I'm not sure, to be honest with you. I'm guessing we're not in.
And now see, I'm filling.
Oh, sure.
So-
close it.
Yep.
Okay.
Sorry.
Sorry, Joey. Thank you for being my dummy.
Okay, so now we're gonna have to do the. She said mannequin.
Thank you for being my mannequin.
So now grab your 2x2.
Okay.
I can do it for you.
Thank you.
Okay. Now put that right
Right
there.
at that spot.
And then
Now,
pull
as
out.
you're pulling out, push down to keep the pressure on it. Okay, and just set it aside for now. So what we probably did is we probably just nicked it enough
To get it.
to get the flash, and enough of a hematoma developed that we got flash back in. And as you pushed, it went off the side, and
Okay.
that's. But now you got an infiltration.
Thank you for letting
Now
me.
you're gonna give me a nice